I'm Jessica Figuera, and I'm a member of the Cancer Center Education Work Group. Thank you all for joining the presentation today. As you join the meeting, your audio will be muted, and please remain muted. We will have a Q&A session following the presentation, and you'll be able to unmute your audio to ask questions. We also encourage you to use the chat feature to pose questions during the presentation, and we will try to get to as many of your questions as possible in the Q&A session. In the chat, you will see a link to sign in for the session. Please take a moment to complete the sign in. This is extremely helpful to us to measure attendance at our virtual sessions. If you do sign in, you'll also receive an email for an anonymous survey following today's presentation. So please complete that, as your feedback is really helpful for us in planning these events. So now let me introduce you to our speaker today, Dr. Breelyn Wilky. Her presentation today is Learning from Every Patient, Translational Immunotherapy and Sarcomas. Dr. Wilky is a sarcoma medical oncologist and clinical trialist with research interests in immunotherapy, targeted therapy, precision medicine, and early phase drug development. Dr. Wilky is an associate professor at the University of Colorado School of Medicine. She is the director of the sarcoma program and active in phase 1 and experimental molecular therapeutics research protocols. As the Deputy Associate Director of Clinical Research, she leads the Investigator-Initiated Trials Committee to help advance novel research to the clinic. Her laboratory conducts studies for tumor and immune microenvironment of sarcomas to identify new drugs that boost the immune system for future clinical trials in sarcoma. I will now turn it over to Dr. Wilky to get started. Thank you.
Thanks, Jessica. Thanks, everybody, for joining today. It's always funny when you hear someone read your biography, you're like, wow, I really need professional help to write it. So maybe you and I can work together on making it like more user-friendly, because it sounds crazy. So that's another project for another day. But thanks again for inviting me to do this talk. What I'm going to try to do today, for many of you on Oakrest who are helping me with an investigator-initiated trial for sarcoma patients, we're going to kind of walk through why we're doing that study and some of the science behind why we think it's going to be helpful for patients, including in the laboratory. So I'm notoriously bad at watching the chat, but I will put it up and try my best to keep an eye on it. So please interrupt me or feel free to ask questions, because some of this stuff gets a little bit in the weeds. I'll do my best to explain everything, but don't hesitate to ask questions if you have them. So let me try to share my screen. Can everybody see big slides? Hopefully. Okay, perfect. And let me open up the chat. Looks like I cannot do that.
We'll keep an eye on it.
There we go. All right, I got my chat. Okay. So so I think probably the first thing to say is, well, what is this translational medicine? Like, what we hear about it all the time, but what does it really mean? And at the end of the day, the reason that many of us want to do research is so that we can take new discoveries or new ideas from the laboratory and get them into the clinic so that we can actually help patients with treatments instead of just working in mice all day. But when we're talking about rare cancers, and arguably every cancer, it's important that we learn as much as we can from the patients who were treated with our ideas to try to figure out why it worked, why it didn't work, and what we can do better. And so basically bench to bedside and back again is the mantra for this idea of translational research. And it's really going back and forth from clinic to the laboratory. And so why is this important? So this is a busy slide, and sorry for those of you that are lunching. I realize that maybe this is not the greatest set of pictures to include during a lunch talk, but sarcomas are incredibly rare and challenging cancers. And the main reason that is because they're not just one type of cancer. Basically, there's about 100 to 150 different cancers of bones and soft tissues. And so when I explain this to patients, I often describe it as the gristle on the chicken breast when you pull the skin off. It's sort of that material that holds everything together. And sarcomas can basically come from cells that are supposed to make up bone, tendons, fat cells, cartilage, basically all of our structural cells. We don't quite know what causes them in most cases. These are not the typical cancers that are associated with smoking or generally not inherited in families. And there's a lot we don't understand about why people get them. But it appears to be pretty random, sort of one of these genetic flukes or a mistake that happens in a cell that's normally supposed to be hanging out and holding us together, but somehow gets damaged and goes back in time to when it's dividing and developing. And so these tend to be pretty aggressive in most cases. So if you take all 100 to 150 of these cancers together, they only make up 1% of all of our adult cancers. In pediatrics, it's about 15%. And if you look at the genetics of these tumors, the pediatric ones tend to be pretty simple. Basically, they're driven by something called a translocation, which is where two different genes that are supposed to be miles apart in the whole genetic code have, again, a genetic fluke and get stuck together next to each other. And when they're put together, they take on a life of their own and begin to drive the cell growth. In most adult cancers or adult sarcomas, it's much more complicated and it looks kind of like a bomb went off. There's a lot of scatter, a lot of different genes that are damaged. And they don't tend to necessarily keep the same sort of nice, similar mistake that we could go after with a drug. Many of these have mutations in kind of the master regulator genes that keep us from developing cancer in the first place, called our tumor suppressors. So genes like P53, RB1, ATRX, and so on. And even within the complex subtypes. So there's just so much heterogeneity, meaning that not every tumor that's a leiomyosarcoma, for example, looks alike, and they don't all respond to treatment the same way. So basically, we're dealing with a crazy basket full of different challenging tumors. What they do have in common is that we desperately need novel treatments. So basically, you can, in addition to the heterogeneity of different genetics and different types, they can occur anywhere head to toe in anybody age, from childhood up to the age of 100. And unfortunately, we've been trying to treat them all the same historically. So these are just some of the standard chemotherapies that have been used to fight sarcomas, including a drug called doxorubicin, which we'll spend a lot of time talking about today. Literally, we've been using doxorubicin since the 1970s to treat cancer, sarcomas that have spread. And to date, none of these other treatments or these other combinations have been proven to make people live longer than doxorubicin by itself, which is really scary. The unfortunate thing, though, is while we've gotten better over time at keeping people alive and, using these new drugs that have been approved since then, at the end of the day, the average life expectancy for adults with metastatic or sarcoma that's spread is still only about 18 months, maybe a little bit longer. So that's with all of our treatments. So we still have a lot of work to do. Particularly for doxorubicin, the time of stability, so progression-free survival, is really only about 6 months. And so what that means is patients go on treatment, but within 6 months, their cancers have developed resistance. And so we're switching to something else. And you can kind of see that most of our drugs are still only about 6 months of benefit before we wind up having to change therapy. So again, sorry for the gross picture, but this is the patient that kind of completely changed my course and made me want to start studying the immune system and using medications called immunotherapy, ways to boost the immune system to fight sarcoma. So this lady, she's lovely. She is a 63-year-old female who had developed an angiosarcoma. So an angio is a cancer of the blood vessels. And oftentimes these occur in older people in areas where the sun is actually exposed. So scalp, head and neck. There's other types as well, but the important thing with these is that they tend not to actually spread that often, but they can be very aggressive locally. And so you can see here, hers started as what looked like pimples on her nose and her cheeks. but rapidly transformed into this really nasty crusting tumor that just took over her face, basically. So the worst of the worst here for women especially. This is an MRI scan, and you can see on her cheek here, the tumor is sort of outlined with these dotted lines, but really an impossible to remove with surgery. So we tried to do surgery, including removing her nose, because this is what we thought was best at the time. This was back in 2013, 2014. And she received a bunch of different chemotherapies that are listed here on the side, including clinical trials. We had her on a phase 1 Notch inhibitor. We had her on various different things, and nothing was working. And so she was actually the first patient to go on a brand new trial. And this was a Genesis trial who was just getting started at that time with a drug called 1884, which is currently in our IIT. This is a regular CTLA-4 inhibitor. So basically a checkpoint inhibitor that's designed to block the don't eat me signals that cancers use to shut down the immune system and keep them from attacking the cancer cells. She was literally the first patient on the study, and she got started at dose level 1, patient 1, at 0.1 milligram per kilogram. So the doses we're using now are 10 times higher, and actually even 30 times higher at 3 mg per kg is what we've used in other diseases like melanoma for similar drugs. So she got this tiny, tiny baby dose of treatment every 3 weeks. And what happened was at day 12, you can see that her tumor pretty much exploded. It became very inflamed and red and kicked off a lot of the scab tissue. And she stayed on for about 18 months. And at the time of her end of treatment, we did a biopsy, and there was actually only scar tissue left. So this horrible tumor that was resistant to everything else managed to completely die with a baby dose of an immune boosting drug. And she remains actually cured until this day. So she's now been off treatment since basically February 2018 and still has no evidence of recurrent disease. So I was super excited. And, my biggest thing was, well, will this work for other types of sarcoma? Will this work for other patients? So I'm not the only person who had this idea. But before I kind of get into what the results have looked like for these immune boosting drugs in sarcoma, let me just take a step back and give you the big picture overview of what needs to happen for an immune checkpoint inhibitor drug like 1884 to be effective. So at the beginning, if our immune system was doing what it was supposed to do all along, it should recognize that a cancer cell in our body is broken. And that's why we don't get cancer more often than we do. Every day, there's billions of cells that have mistakes that your immune system recognizes and kills off before they have a chance to become an actual tumor. And this is because cancer cells have different proteins. There are broken proteins or antigens that are released in the process of the cell either dying or as part of the usual housekeeping. All cells take their own individual proteins and stick them on the surface with a protein called MHC as part of their surveillance, right? So it's a well-organized system. Everybody has to present their proteins for the policemen, which are our immune system, making sure that nothing's wrong. So for a cancer cell to be killed, it has to have something unique about it, good antigens that then trigger the policemen, the antigen-presenting cells that come around and are checking for broken cells or cancerous cells. If they find something, the antigen-presenting cell then travels to the lymph nodes, our glands that are sort of our powerhouses for the immune system to hang out, and they come face to face with T cells, which are the master cells that have the ability to be specific for antigens and can actually kill off cancer cells directly. So priming and activation here, it depends on CTLA-4. So that's one of the markers that regulates the priming and activation of T cells in the lymph node. Once you have tumor-specific T cells generated, they then have to be able to get back to the tumor. They have to get in, which is sometimes hard for big tumors because the blood flow is crappy, or there's all these nasty factors in them that make it hard for T cells to live and thrive. But if they get in and they get face to face with a cancer cell, at that point, they're supposed to kill them. Literally head to head, they kill off the cancer cell. Now, cancer cells, as well as our normal cells, have other proteins like PD-1 or PD-L1, which are don't eat me signals that literally turn off the T cell right at that last moment, right as the T cell is there head to head with the tumor. And so this is where checkpoint inhibitors have been helpful. You block the CTLA-4 molecule, which allows for better T cell priming and education. And then you can block PD-1 or PD-L1, which allows for, if the tumor or the T cell gets into the tumor, to allow it to kill. So there are drugs that have been developed for both of these targets. And what I'm going to show you here is what's been done in sarcomas specifically. So pembrolizumab and nivolumab, I'm sure you guys have heard through the trials, but these are both PD-1 inhibitors, so they act at the very end. And if you look at sarcomas that were treated with these drugs by themselves, it's pretty lousy. So only about 18% of sarcomas had benefit with PD-1 inhibitors alone. And we think that the reason that might be is there's a failure at any one of these steps, right? So if you don't have good antigens, if you don't effectively teach your T cells, or if they can't get in, you can do all the PD-1 blockers that you want, but it's not good. There's nothing to activate. There's nothing to stimulate to grow. So we started doing combos with checkpoint inhibitors and other drugs that were designed to counteract each of these failures. So for example, a drug called axitinib is a pill that helps to make a better microenvironment. It helps to make the blood flow better and allow the immune cells to leak into the tumors. That didn't work particularly well either. We're still only about 10% shrinkage rate and only 3 months of stability for average. Then people combined CTLA-4 inhibitors with PD-1 inhibitors. So hitting at both steps here, drugs called ipilimumab and nivolumab, still about 16%. So that wasn't the answer. Cytoxan, which is a medicine that helps again to trigger and make your policeman more effective. So basically getting rid of the suppressive policeman, the suppressive antigen presenting cells. That really didn't work. And then what we'll talk about a lot today is combining chemotherapy, specifically doxorubicin with pembrolizumab. And here, this study, which we'll talk about more, again, only about 22% shrinkage, but a little bit better stability, so closer to 8 months. So basically, there's still something, we're still missing something in order to get the immune boosters to work for all patients with sarcomas, not just our super angiosarcoma responders. Why is this? So I'm not going to go through this in a ton of detail, but basically this group out of France looked at somewhere about 300 sarcomas of 3 main types. So liposarcoma, which is fat cells, leiomyosarcoma, which is muscle cells, and then a disease called UPS, which is a tendon cell or a fibroblast, the gristle on the chicken breast type cell. And what they did was they looked at the relative expression. So how much of all of these different immune process genes were activated and highly functional in the tumors themselves. And you can see T cells here. You can see CD8 cells, which are the ones that are actually killing, natural killer cells, and so on and so on. And basically, this is a heat map, which means everything that's blue is low expressing, meaning there's not very much immune activity, and everything that's red is hot or very high immune expressing. And across the board, you can see there's about 20% of sarcomas that have really, really high levels of immune activity. And most of the rest of this is very cold. There's not a lot of immune activity going on. And they went on to basically show, and without getting into the weeds too much, that the red tumors or the hot tumors with that high immune activity were the people that were actually getting better shrinkage with pembrolizumab or with PD-1 inhibitors alone. So that kind of explains why only that 20% will respond to the checkpoint inhibitors by themselves. So we have to assume that everybody else, there's a failure earlier on in the process. They're not generating T cells to be activated. So that's basically what I'm saying here. Immunotherapy can work for some sarcomas if they've been recognized as foreign, they've been able to successfully stimulate tumor-specific T cells, and the T cells can get into the tumors and be activated by the checkpoint inhibitors. So we need to help out most sarcomas at these above steps if we want to be able to use immune therapy. So how do we do this? So this is a busy figure, but basically I want to talk a little bit about this idea of an immunogenic cell death. What does that mean? So if you look here, here are our cancer cells. Now, cancer cells and any cell can die in multiple different ways. You may have heard of something called apoptosis, which is like cell suicide. That's a very quiet death. So the cell is damaged and it gets signals to abort itself basically and kill itself off. Now, the opposite of that is when a tumor gets crushed. So imagine your cells, you've got a crush injury or something, and the cells are just destroyed and there's all this material leaking out everywhere. That's called necrosis, which is much messier. Now, in between the two is what's called immunogenic cell death. Immunogenic means that it is recognized by the immune system. So if you use a medication at this point that induces immunogenic cell death, what happens is that the dying cancer cells release particles that stimulate those policemen, the antigen presenting cells, to come in and recognize the cancer cells as being bad. And so there's something called DAMPs and PAMPs, and these mean damage markers and pattern markers, which basically are the most important chemicals to trigger the policemen, the antigen presenting cells, to go there. Another one of these chemicals is type 1 interferons. And so basically, if we were able to find drugs that boost this initial process, in theory, this is going to help at the beginning stages of that pathway. So making sure that your immune system recognizes that there's a problem and wants to go to work to be able to generate T cells and go back and kill off the tumors. And so doxorubicin happens to be a very potent inducer of immunogenic cell death. So in addition to killing off cancer cells directly, which it can also do, when it does that, doxorubicin has been shown across the board in many different types of cancer, breast cancer, any cancer where you're using doxorubicin. It causes the tumor cells to release those DAMPs, those magic proteins, and especially type 1 interferons. So all of that stuff gets dumped out if you treat tumor cells with doxorubicin. And then basically, it's also been shown that the policemen or antigen presenting cells increase with doxorubicin treatment. So they go back into the tumor in a better fashion. And the T cells increase as well, going back into the tumor. So basically, doxorubicin is a great drug to boost the immune response early on. And so we asked the question, well, what happens if we combine this with checkpoint inhibitors? So if you boost the early recognition and then enhance the activity of your T cells, does that make things better? So we weren't really the first people to figure this out, because I told you there was a trial that looked at doxorubicin and pembrolizumab, which is the PD-1 inhibitor. And this is just looking again at that data. And you'll see that most patients had stabilization of their disease. This is a waterfall plot where each bar is a patient. If it goes down, the tumor shrank a certain percentage. This is why we do RECIST logs, is so we can show these lovely, cute little waterfall plots. If it goes up, then the tumor actually increased as the best response. So there were some patients that did have shrinkage of more than 50%, which is pretty amazing. And some of those patients, which you can see here, had that shrinkage for a long period of time, so even years. So again, there's a subset of patients that do really, really well with this, but there are a lot of patients that didn't respond at all. So this is our IIT. What my argument is that actually you need triple therapy. So the doxorubicin, again, boosts that initial signal with immunogenic cell death. And then we use two medications, a PD-1 inhibitor like pembrolizumab. This is Agenus 2034. And then an antibody to CTLA4, which is 1884. And we do all of this at the same time and think that we'll be able to actually improve the outcomes. And so this study, we, as many of you know, we're about halfway through putting patients on right now. We're at that first phase where we look to see how people are going to do. And the idea is that we're hitting the immune system from all angles. So I'm not going to show data today just because this is being reported and we need to actually work with our statisticians. But suffice it to say, there are some patients that seem to be having benefit already. So we're really excited. So that's sort of the background for the trial, but how are we going to learn from every patient that goes on this study? Because again, rare diseases, not very many trials. We need to really understand who benefits from this, and if it doesn't work, why? Fortunately, we also have some mice that can help us out with this. And so in the sarcoma research program here, what my lab tries to do is create that bench to bedside and back again approach. So we have patients that go on clinical trials like our immune therapy trial, or I also have patients who are just having surgery for their sarcoma. And so we have a tumor banking protocol that makes sure we collect extra tissue so that it can go into mice. We collect tumor, we collect blood from patients, whether they're on treatment or not. PDXs, this is where you take a mouse with no immune system so that you can put human tumors in there and hopefully they grow. And we've had about 5 of those take since I got here and started up this program. So we've got human sarcomas that we can grow in mice and treat with some types of treatments. What we also do with the tumor tissue in the blood is we do a bunch of immune cell profiling. So we're looking at what kinds of immune cells are in the tumors, the policeman type antigen presenting cells, the T cells. Are they active? Are they sleeping? Are there not enough of them? All of these different things. And so we actually grow out the tumor and the immune cells that are in the tumor into these big cultures so that we can study and modify the immune cells, the T cells that are actually inside the tumor and presumably are matched for the tumor itself. We have mice that do have their own immune system. So I'll show you some pictures and talk about some studies that we're doing in mice that develop their own sarcomas. Since you have a mouse immune system, you can actually test immune therapies using these models. And then do the same sort of immune profiling in the mouse sarcomas to try to understand why it works or why it doesn't work, and hopefully bring this back to patients in your next trial, which will hopefully work better. So for this particular study, what we're doing is we collect, again, blood and tumor biopsies, which is why the budgets are so big and which is why, Denise cringes every time we want to include correlatives, but this is why it's so important. So for these patients, they get a biopsy before treatment and on treatment, and we are doing basically what I had mentioned. So looking at the immune cells in the tumor and in the blood, cytokines, which are basically the chemicals that drive immune responses in the blood, certainly whether the tumor responds or not. And then we're actually doing sequencing, genetic analysis to look at the particular tumor proteins that may be triggering the response and how they match up with the T cells, the T cell receptors, which are what give the T cell the specificity to go after a particular tumor protein. I told you about making our sarcoma models. So each biopsy, one little piece will go into a mouse. Eventually, the goal is if we get enough of these to take, we will actually have a mouse tumor that mimics what happened to the patient. So if we have a tumor that we took from a patient who goes on to respond to treatment, meaning the tumor shrinks, and then we have a resistant patient as well, then we can really learn a tremendous amount and understand what happened in the human, but also what happened in these mouse tumors. And ultimately, we can study this in what's called a humanized mouse model, which I won't get into in too much detail. But essentially, these are mice where we've put in a human immune system so that we can tweak it and try to kill the human tumor that's in the PDX. These are our models that I'll talk about. This is a separate process, again, with the mouse sarcomas that have mouse immune systems already. And what we're going to do and what I'm going to show you is some work we've done doing the exact same thing we're doing on the trial, but doing it in mice. So doxorubicin, the chemo alone, versus the immune therapy alone versus the combination, and trying to understand how we're affecting the immune system that way. So these are our cute little mice. So basically these mice have a sarcoma cell line. So basically this is tumor cells you can grow in plastic and then inject into the flanks of these mice. And because they're so aggressive and because they originally grew in the mouse, the sarcoma will actually form on the flank here. And so we can monitor the development of these. So we inject those sarcoma cells, Takes about 2 weeks to grow into a tumor that you can feel. And then we started treatment with either nothing, just to kind of see what the tumor would do on its own, chemotherapy alone with doxorubicin, the antibodies are blocking PD-1 and CTLA-4, or the whole kit and caboodle, the combination. So these are what are called tumor growth curves. And so the MCA205 model, which is a fibrosarcoma, basically showed that the combination, which is shown in red here, sorry for anybody who's colorblind, the bottom line here showed the growth suppression. So less growth over time compared to the control, which is in black, or either treatment by itself. So using the triple seemed to help slow the growth more. We did not see this in the KP sarcoma model, which is more of a resistant model. And so this is important. This says, okay, well, there's something different about this model where the strategy works, whereas in this one, you don't really affect tumor growth at all. Why is this? Well, these are some microscope pictures that we're just working with now, so it's very early. The MCA205 one, the one that actually shrunk, is shown here on the left, and the KP one that didn't work is shown on the right. The tumor cells are shown in turquoise, and again, sorry, this probably doesn't project particularly well on laptops. And then all of these different other colors are immune cells that are in the tumor. And basically you can see that this thing is loaded with tumor cells or with immune cells. So yes, you can find these little turquoise tumor cells in here, but there are immune cells all face to face with the tumor cells in this model where the tumors are getting slowed down. Both of these are treated with the chemo plus the immune therapy. In the resistant model that didn't shrink, there's almost no immune cells hanging around. Almost everything is tumor cells just packed in there. There's one little T cell, one red T cell hanging out over here, but that's about it. Okay, so something is not charging forward, which fits with what we were expecting. So then what we went on to do was we took the tumors from mice that were treated with MCA205. This didn't make sense to do with KPs since there were no immune cells in the tumors. But we took out all those pretty colored immune cells that we were looking at, and we digested them into a liquid, basically, so that all the cells were by themselves and no longer in a tissue form. And then we looked to see about the T cell markers. So what kind of T cells were in there? Were they activated or sleeping? And we started to look at something called tetramers. So what does this mean? So if you remember, we have immune cells that are specific for every infection or every enemy that our bodies ever encounter. So for example, when you get a flu shot, the whole point of getting a flu shot is you make T cells that are memory T cells that can kill off flu viruses anytime in the future, or at least that year until the whole thing changes, you have to get a new shot. So you've got memory cells for flu hanging out. When you got your COVID-19 vaccine, you're generating a whole new supply of memory T cells that are specific for COVID-19. So the point of this is that in tumors, it's the same thing. Every different protein that a tumor cell might present to the immune system will have its own set of T cells potentially. So what we were trying to do is looking at something called the V beta region, which just is a measure of how specific the T cells are. Like, are there, because if you look at you or me, we've got T cells across all of the different V betas. There's about 18 or 20 of these things. So it's very scattered. But if you have a whole lot of T cells that are specific in one group, then the question is, well, maybe we're boosting an immune response towards one particular type of target, one particular protein or something. So that's what we were kind of looking at, is what we call the clonality. How many different things are being represented in the immune cells that we pull out of these tumors? So basically, this is flow cytometry. So this is where we use all those different antibodies to understand what types of cells, what types of T cells are in there. So basically, if you look at control cells, meaning no treatment, the chemo alone, the immune therapy alone, or the whole combination, CD3 is a marker for T cells in general. And of all the tumor cells and all the immune cells that we put through this assay, you can see that the combination, all the triple, gave us 67% T cells in the tumor compared to 45% in the control or 48% with the immune therapy alone. So a lot more T cells were in the tumors when you compare after you treat them with the triple combination. And if you look at what type of T cells are in there, basically these are called UMAP plots. They're very fancy things that I won't try to explain today, but look at the blue. So the blue is basically every dot here, there's teeny tiny little dots. Every dot represents a cell. And this is a way to look at what kind of cells are in the whole population at one time. So in the control, it's about 50-50 blue, which are the killer T cells, and then orange, which are the helper T cells that don't have that direct cell killing for tumors. And as you go across the groups, again, the triple treatment, there's much less CD4 helpers, but a whole lot more blue killers, right? So we're actually inducing more of these killer T cells to get into the tumors with treatment. And what's important, again, blue is the killers, and you can see with the different treatment groups, it goes up if you count these. What's important is that if you look at the normal population in the mouse of immune cells, like in the spleen where they hang out or in the blood, you're still mostly seeing CD4 helpers. So the point is that the tumor-specific killing is in the tumor. It's not just because you're increasing killer T cells in other places in the body. It's really specific for the tumor with the treatment. This is a really busy slide, and I'm just going to point out what you need to know. But this is basically looking at those different clones of T cells. And the take-home point here, each of these little bars represents a different clone, if you will. And when you look at the combination treatment group, what we see is that the bright green group, the 5.1, 5.2 family, or the clone, is much higher here. There's a ton of these cells hanging around in the treatment groups. These are all among the killer T cells compared to the low greens in any of the other treatment groups. So we're in the process of driving all these killer cells into the tumor. We're also changing the distribution. There's a lot more of the 5s as well as the 8s and the 8.3s in the tumor compared to other treatments. So something is remodeling what's actually being shoved into the tumor. I know it's weird, so you don't have to understand it completely. And the last piece to that part is if you look just at the 5s, that big spike across the different groups, most of these have markers that suggest they are active, have the potential to actually kill tumors, which is these other checkpoints, 4-1BB, TIM3, and a ton of PD-1 here. So basically, we're driving in activated angry T cells that are presumably specific for some tumor marker that's in the family of the 5.1. This just basically says that we didn't see that clone as much in the spleen or the blood either, and it was sort of distributed more evenly, so we don't have to worry about that as much. So the last piece here is, okay, well, are we actually doing what we think we're doing? Which, does the CTLA-4 actually matter? Or can we just give CTLA-4 and doxorubicin or PD-1 and doxorubicin? Like I told you that I thought adding that was going to make our study better than just the doxo PD-1 study. Does that even look like that's the case? And when you look at the tumor growth curve, so in this experiment, we took those sensitive mice and we gave them every possible combination, and the bright purple is the triplet. And yes, the bright purple is at the lowest end, the slowest growth rate, but it's hard to tell if it's really that much better. But this is a plot where you look at the growth percentage each day. So if you look at the tumor, what's the average percent among all the mice that the tumor is getting bigger? Only the triple had the lowest percent growth. So this is somewhere about 18% growth per day, whereas the other groups all had somewhere higher than 27 or so. So 27, 28% growth per day. So there's something about the triplet that is driving the immune cells to actually be more effective, we think, and kill off the mouse tumors. So that's basically the work that we're doing. And so now we have that set up in the mouse that we're trying to understand why this is happening. And we have the patients that we're going to learn from whether or not it actually works. And if not, why. Well, what about something else to boost that initial recognition besides just doxorubicin? So the other study that we're doing in our lab is basically looking for new drugs that can boost the policeman to recognize the cancer as being bad. So we have a drug library of about 2,500 different drugs besides doxorubicin. And we have this robot where we can put the sarcoma cells, we treat them with all of these different drugs, and then we put antigen presenting cells that we have in the lab. So these are actually human antigen presenting cells that we put with the sarcoma cells together. And these guys spit out a couple of colors. This one is blue, the SEEP, and the luciferase is bright green. So if you activate the antigen presenting cell and make it ready to go to a lymph node by the treatment with the sarcoma in here, then it'll spit out these colors and you can actually see if you've stimulated the cells or not. So we're in the process of trying to get all this to work, but the idea is that we're looking to find new targets that we can combine with checkpoint blockers that will hopefully be better at inducing those immune signals that we can ultimately test in mice. So in summary, what I've shown you, I think, is that sarcomas are not all the same, and that unfortunately we're not going to be able to get those magic responses in all patients like we did with my angio patient. And so the more we learn about what's going on with the immune system, we can customize treatment. Basically, if the tumor is not recognized or if the antigens are not recognized by the policeman antigen presenting cells, maybe we need chemotherapy or some other immunogenic cell death. If we can't grow T cells, maybe we need to pull out those T cells that are in the tumors and do something called TIL therapy, which I haven't even talked about, but basically just giving the patient back their own immune cells that are in the tumors that we've grown into armies of billions and billions of cells. And then there's all of these other different immune cells, not just T cells. Maybe we need to be rigging those so that they make a more favorable place for our immune system to fight in the tumor. But the take home of all this is because we're not going to be able to do a trial for every single combination, for every single type of sarcoma. We've got to think smart. And that's why it's so important that we learn from every patient in the trial and we use our lab to model as best we can. I mean, one mouse model is like one patient, right? You're never going to see the whole thing. And you're not going to capture how different patients are from each other. But at least it can give you something to go on and try to understand what we're seeing in resistance versus patients who do well. Eventually, my goal is to customize the immune combos based on what their immune system looks like, not just what type of sarcoma they have, which has been the way that we've been doing it so far, because not all sarcomas are created equal either. So just to give you a picture, we're kind of doing this in the clinical trial space here at Colorado. So we do have another Agenus protocol with a next generation CTLA-4 drug, and they are specifically looking at angiosarcomas like our patient. And in this study, this is going on through POEMS, and our team has put 4 of the angiosarcoma patients on. So we're hoping that this will actually help to prove that this disease needs an approval for immunotherapy. We talked already about the chemo protocol, again, hoping that this will help to boost the immune recognition of cold tumors that are not well recognized. We are running another trial as a partnership with Washington University that is also an IIT, but they're leading it. So we're kind of the secondary. And this is combining a blood vessel blocking drug. So this involves the microenvironment, meaning that maybe we can't get the cells in, or if we use these medications, they may make the environment more favorable for our immune cells to live. And so this drug, cabozantinib, is being combined with checkpoint inhibitors for sarcomas, and this one should open hopefully in a couple of months. We're going through startup now. And then sometimes we're looking also at other ways. So you had mentioned just avoiding the whole antigen problem to begin with. And if you know of a target that's on the surface of your tumor cells, you can try to rig and design a specific T cell for that target, right? So you don't rely on the body to do it. You just shove it in the T cell and then grow up an army. And so we have a synovial sarcoma protocol like this for MAGE-A4, which is a target that's often on synovial sarcoma cells. And this has looked really promising. So with this, you basically test the patient up front to make sure they have MAGE-A4 on their tumor, which, as we've learned from our one and only patient we've been able to get on the study, is not always consistent. But you take out the patient's immune cells, and then you grow them up and you force them to put a receptor that's specific to match for MAGE-A4. So you train them, just like instead of allowing them to be flu specific or COVID specific, you say you're going to be MAGE-A4 specific, and you're going to shove that receptor into the cells, grow them up into billions, and then give them back to the patient. So we are doing this for synovial. And then the TIL therapy that Eduardo Davila, my lab partner and collaborator and mentor, is working on is basically going to take a chunk of tumor out, pull out the T cells that are in the tumor already. So you don't have to know what the target is. You don't have to know which one's important, but you just expand them and grow them up. And then he uses a particular construct that makes them more prone to being activated. And so the idea is we'll have customized TIL therapy that we can then give back to patients. And this will hopefully be happening in the next year or two. But it's a process, because this is a true bench to bedside thing that we have to do all the work for the IND. There's no pharma company to do this. So it's a process. But so very exciting, lots of things going on. And I hope that I have made you guys understand a little bit about why the science is so important to drive clinical trials, and how important you guys are into making sure that we actually get good data out of these trials, and that we're able to learn from every patient and put it all together. So this is our lab. This was kind of in the middle of COVID. We're sort of social distancing here, so sorry about that. But I'm the people who have done some of the lab work in the mice. Eduardo, who I mentioned, and then many people, including all of you guys who have helped me get this off the ground. So with that, we've got about 10 minutes for questions. So please unmute and ask away. Thanks, guys.
Thank you, Dr. Wilky. Yes, please add in the chat box if you have any questions, or unmute yourself and feel free to ask those questions.
Dr. Wilkie, I actually have a question.
Yeah.
So the patient that you showed the progression photos for, do you have an estimation about how much time that original tumor took to grow to what it was at that first photo?
Yeah, so that probably took, I mean, I met her and she just had a little bit of scattering. The problem with angios is they're always worse than they look on the surface. They grow with these fingers and these satellites, and they're always way more extensive than you would have thought. So you can think there's a couple spots here, here, and here, but it's really quite extensive. And that's why surgery doesn't work. You never get everything out. I think I met her not that long after I got there. She probably 2013. And then we put her on study, I think 2015. So maybe 18 months or so. And that was despite all of the treatments.
Gotcha. Thank you.
And then it looks like we have a question from Yaping in the chat. Has Doxo and immune therapy combo been tested in pediatric sarcomas? Great question. So the pediatric sarcomas that are driven by the translocations, so we're talking Ewing sarcoma, rhabdo, osteosarcomas, there was just as much excitement to try to see if the immune treatments would work in those diseases as well. And at least by themselves, it was a disaster. These tumors grow so quickly, and the immune system doesn't have a chance to catch up, or there's other reasons that they can't recognize them as being bad, maybe because they are kids or pediatrics, we don't know. I think the Doxo combination with the immune therapy has not yet been done in kids. We think it needs to happen, but in children's sarcomas in particular, children's research, it can often be very challenging to get those new ideas out there, only because, again, the risks are so high, right? To go too far out there is potentially quite scary to everyone. So I think if we are able to prove that this is safe, because part of this is looking at, we're the first people to actually put both immune drugs along with doxorubicin. Nobody's done that. So if we can show that it's safe in adults, then I think it would be very reasonable to try putting that with the chemo backbone. Why are sarcomas more common in kids than adults? That's a great question. I think in general, the numbers may not be completely accurate. I think part of it is in kids. So if you look at bone cancers, for example, bone cancers bones in children are growing, whereas in adults, bones are supposed to not be growing. You're done growing. And so whenever you have a cell that's actively growing, like the only time in adults where connective tissue cells should be dividing are for repair of injuries, right? And so that's where a lot of people swear, they're like, oh, I hit my leg on a shopping cart and then I got a sarcoma in the same spot. Or, somebody has surgery and there's like an injury and they're like, oh, that's where my sarcoma came from. I think whenever those cells, which are supposed to be dormant, are actually growing, which happens in kids, it just sets the stage for something to go wrong. It's not that it causes it. Like otherwise, everybody who ever got injured would have a sarcoma, or much more common. But when everything's flipped on and there's all those genetic changes, and in children, when the bones are actively growing, one little glitch, one little mess up can potentially cause a problem. Does that make sense? Other questions?
Yeah, during your education and your training, what sort of attracted to you, quote unquote, to focus and specialize in sarcomas?
That's a great question. So, I didn't know what one was. I was a first-year fellow in oncology, and my first week on consult, where we go around with the attending and we see new patients in the hospital, we had this woman who actually had another angiosarcoma. Now, hers was not on her face like my lady. They can also develop in the spleen or in the liver, in organs. And this lady was like 30 something years old. She was beautiful. She was a dancer from the Bahamas. And she had basically had this massive tumor in her belly. She couldn't eat. She couldn't do anything. And I started Googling frantically because I had to present to my attending. I'm like, I don't even know what an angiosarcoma is. And, we realized very quickly, like at the time in 2012, that was before a lot of this stuff had even been developed. Even the new medicines that I showed you on that chart, a lot of it wasn't even done yet. And so my attending, she was amazing. And she's kind of helped me figure out, well, we don't really know what to do. There's not a good randomized trial, but she had spent time at MD Anderson, where they see more sarcomas than anywhere else in the country. And she's like, I think we should do this, this, and this, which was traditional chemo. And we fixed her. Like her tumor got smaller. She was out of the hospital. She was eating. It was amazing. And then like 3 months later, it just relapsed like that. I mean, it just exploded back again. And that's what happens. A lot of these, you can get initial stabilization with chemo, but you'll never cure them. And she wound up dying, I think like 9 months or 10 months after that. So part of it was just, wow, like I want to be that person that, is the expert for these super rare diseases, because no one wanted to deal with sarcomas. It was always Katie Thornton, who was my mentor and the sarcoma queen at Hopkins. But at the same time, it was like, okay, if I'm going to figure out anything, or if there's any research that we do that explains something or could help someone, it's going to go so far with this group of tumors because no one or very few people do focus on them. Breast cancer, on the other hand, I was like, there's no way I'm ever going to be able to come up with a new idea compared to with all the people that do breast cancer. So for me, it just seemed like it was a chance to be part of something that was special and weird and unique, with the potential for big input. Plus the patients are amazing. And any of you who have ever met my patients or if you've come to clinic, I mean, it's an incredible group of people. Anybody else? Well, feel free to email me later if you have a burning question or you had no idea what I was talking about, because again, the immune system is so complicated and it's really hard to understand for everybody. Like nobody really understands completely. So if you do have questions or something is burning, just let me know. And yeah, thanks to all of you who support clinical trials and these crazy laboratory scientists and doctors who think they have all the bright ideas. We appreciate your patience and all of your help with everything.
Thank you, Dr. Wilky. That was a phenomenal presentation, and we appreciate your time.
Anytime. Have a great rest of your day, guys.
You too. Thank you.
Bye.
Bye.